in fact, this is not really all that unusual. Right now, 70% of all cancer deaths are in low and middle income countries, and the incidence of cancer in these countries is skyrocketing as people live longer and have time to develop cancer with their nutrition and other issues being better taken care of, and as they pick up our cigarettes and some of our other habits. In addition, if 70% of these patients really have severe pain, and as is shown here in the New York Times article in 2007, showing that the drugs were banned and the poor are suffering, it is a huge problem. So just to illustrate the problem, the United States has 5% of the world's population and consumes 51% of the world's morphine. If you look at Europe, that's another 31%, Canada, Australia, New Zealand, Japan. So in fact, the other countries which have 90% of the world's, 80% of the world's population have access to 5% of the world's morphine. That's an overstatement of what they actually have, because this is just morphine. It doesn't account for our oxycodone or our hydromorphone or our fentanyl. So it's actually that they have a far lower access to all of the world's opiates than is even stated on this pie chart. And if you look here at the bar graph, I just took the population of the countries, the amount of morphine, again, no other drug, just morphine, and we divided it so the amount was available per 1,000 people. You can see here's China, here's Mexico, where, by the way, the first oral morphine was given in 1980. Here's Indonesia, a huge country. Here's Nigeria, the most populous country in Africa, and there is no pain medicine available for these patients. Keep in mind that if you were one of these countries and you had a limited amount of morphine, would you give it to a cancer patient? Or would you give it to people who are post-op who would need it for a couple of days, and then you would give it to more patients rather than using a large percentage of your material on a single or a couple of patients? So we spent a lot of time with the health ministers in these countries, talking with them about how we could change it. One approach has been to talk to these countries and say that they're being unethical, and by not providing pain medicines for their patients. It's not an argument that I'm comfortable with at all. I mean, it's why are you just focusing on pain medicine? It'd be nice if they had clean water, it'd be nice if they had food, it'd be nice if they had antibiotics. And I don't think that that gets us anywhere. So the question was, could we give them something that would work better in their local situation? And we came up with the idea that we bounced off of them about whether if we had a small implant that was under the skin, that might be a reasonable idea. And just to explain as to why, they have a limited amount of pharmacy money, and again, they have to decide what they're going to spend on vaccines and everything else, and opiates falls off the end of the list because you are investing in people who are going to be dying in a few weeks or months. They're very worried about whether the villagers would be compliant taking drugs every 3 to 4 hours, because they certainly couldn't afford the long-acting drugs. They're very worried about having these stored in huts with no place to store it, and a lot of kids around, and that people are going to accidentally use it wrong. And they're very concerned that people who are poor, if they had kids and they had no money, would sell the money to be able to feed their kids. I think the rest of us would agree that that would be a very reasonable thing to do, but that's not, they don't need the kind of problems we have in East Baltimore there to deal with as well. So we came up with the idea of developing a polymer. The problem with putting opioids into a polymer is when you do that, there's a burst release. If you're doing this with a hormone for contraceptive purposes, you get a burst of hormone, it may not be a big deal. But if you're doing this with a month's worth of opioids and it all comes out, you'll end up with a dead patient. So working with biomedical engineering at Hopkins, what we did is put the hydromorphone in a polymer that's shaped sort of like, it's about the size of a shirt button, and we coated it with an impermeable coating so no hydromorphone could get out at all. We then put a hole in the middle of this polymer so that the only way the hydromorphone could get out is through this central uncoated channel. And when you do that, here's what happens. So if you have an uncoated polymer, you get this very high burst that would probably do the patient in. But if you have this hole, you get a steady level in the test tube, and if you put it into rabbits, again, there is no burst, and there's sustained release for 30 days. The nice part about this is it's all controlled by geometry. It's all pretty simple. So this is the standard polymer, and again, it releases for 30 days, and then it falls off. If you'd like to make a polymer that releases more micrograms per hour, all you need to do is increase the uncoated surface area. So you make this a thicker polymer, which increases your uncoated cylinder, and you release more drug than the standard polymer. If you'd like to make it one that releases for 3 months instead of 1 month, you increase the diameter of the polymer so that the hydromorphone out here takes longer to get to the central channel, and you basically have pretty good control over what you would like to do. So this would provide a continuous infusion, no peaks, no troughs, no pumps, no needles or injections, a reduced risk of drug diversion because it wouldn't be in homes where people could sell it or in pharmacies where it's frequently stolen, a decreased risk of accidental misuse because it wouldn't be on the countertop at home, compliance wouldn't be an issue, the placement's easy, you just put a little topical lidocaine on the skin, make your incision, slip it under the skin, and put a steri strip on top. And again, if we can't make this inexpensively, it won't work in these settings. So it has to be inexpensive, and we're using only components that are already approved for human use. It's not all that easy in many senses. You have to be careful because it's really going to provide a continuous level of opiates. So if patients' pains are increasing, it's hard to change the rate without putting another polymer in. You really need to know what your dose requirement is before you insert it, so that there's a titration part that you have to do. And again, clinicians are not used to putting in pain polymers, so there'll be a learning curve, and the learning curve will be more in developing countries, where in fact hydromorphone is not an approved agent in most of these countries. You can say, why didn't we use morphine? Hydromorphone is 6 to 7 times more potent than morphine, so our polymer size can be 1/6 or 1/7. And also the physicians there, because the opiates haven't been available, they actually don't really know as much as they probably should know about how to work up and titrate and treat pain problems. I just mentioned that in fact animals also have pain, and in fact we don't do a very good job of treating them either. And many of the animals who are operated on go out to the field, and theoretically somebody's supposed to go out there and inject them with opiates every 3 to 4 hours. I don't think that's going to happen. So in fact, this kind of thing might be useful in an animal setting as well. So take-home messages, the opiates are really needed. The preferred route is oral. If you have that, that's great. If you don't, subcutaneous route is a reasonable alternative. And our novel implant, our hope is we'll deliver this for weeks to months. It will not be magic. Much of what we do in medicine is a little bit like putting racing stripes on a snail. He looks fancy, but he actually doesn't go any different speed. I actually think this kind of thing would actually make a difference to patients. But as we mentioned, it's not perfect. This isn't going to provide the PRN dosing that our patients really do need. However, perhaps a little bit of something is better than what these folks now have available. So thanks very much, and I'm glad to answer any questions, but I know